Okay, I was wondering about that. Thank you. Is that Antoinette? Got it. Okay. So in terms of a presentation overview, we are want to talk a little bit about just the scope of psychosocial oncology services at the Odette. It's a bit of a shifting definition, and I'll explain what I mean by that, but just to help clarify this for everybody. Also, we want to help distinguish among and between our respective psychosocial oncology services and disciplines, because there is quite a bit of overlap. Also, helping you conceptualize, what we think as our appropriate referrals to our practices. And Elie is going to be walking us through a framework that he uses in his consultation liaison psychiatry practice in general, but is very relevant to the patient care we give at the Odette. And also, we'll be speaking to guiding principles of care, because we need them, frankly. There's never enough service and never enough of us to go around. And so we have to operate by some higher level principles that help us, we think, give as much as we can to as many individuals as possible and providing as adequate care as possible. So it's a balance we're striking. We'll be talking about that. And also the scope of service. Later on, Andreia will help speak to the different types of treatments that we provide, referral criteria, and the lengths of treatment between our two disciplines. So the focus today is going to be on psychiatry and psychology. And then at the end, we'll have hopefully ample opportunity for question and answer. And I can't see the full group. So if you do have questions around clarification, if something's not making sense to you, I'll invite those questions. Just raise your hand. You'll be bumped up to the top of the screen here for me, or Elie or Andreia, or feel free to unmute yourself and just ask for points of clarification. But in terms of broader, deeper kinds of questions you have, let's wait until the end. I think we will have time for that. So the Patient Family Support Program and Psychosocial Oncology, let's just begin with some definitions and just to help orient us here. Now, actually it's interesting, our Patient and Family Support Program at the Odette very much mirrors the Cancer Care Ontario definition of psychosocial oncology, which is very broad. It includes not only psychiatry, psychology, and social work, which is more the traditional definition of psychosocial oncology, but also includes OT, PT, and nutrition. And even though maybe they're indirectly related to the mental health components, but still very important to the mental health aspects of our patients. Spiritual care, of course. At the Odette, we're very fortunate to have an art therapy program, which pivoted really well during the pandemic. And so that used to be in the waiting area, actually, and now has been online. And so it is a broad way of thinking about the services that we provide. Adjunct care is another way of thinking about it, but still essential care. And so, but today we're going to be adopting the more, I think, traditional definition of psychosocial oncology, which is inclusive of social work. And I think one of the questions many of our referral sources and patients themselves wonder about, frankly, is when and whether and who and who's the best person for the kind of issue that I'm struggling with, or my patient is struggling with. And so that always raises questions about which discipline makes the most sense to refer directly to. And to be frank, there are areas of overlap between us. And one of those is always going to be the mental health counseling and emotional support aspects of what we do. We all do that. That's the foundation of what we do. We may be using different tools, different methods of engaging our patients or clients, but ultimately, very much, I would say the counseling and emotional support is kind of like the bedrock of what we're all doing. And then how do we distinguish ourselves? Well, for sure with psychiatry, if you're looking for consultation around how best to utilize psychotropic medications, that would be a great use of psychiatry. If you're thinking a patient would be particularly inclined or best suited for pharmacotherapy, in addition to psychotherapy, but maybe very much they need to be on an antidepressant if that's your feeling, by all means, or any other type of medication, then psychiatry would be your go-to discipline. There's also for evaluating complex drug interactions between the psychotropics and all of the other medical and cancer-related treatments they're receiving. If they have a history of psychiatry or severe mental illness, again, I think our psychiatry colleagues are in the best position to at least be the initial first stop for those patients and for patients who are at risk of self-harm. And again, because psychiatry has that connection to our larger psychiatry program outside of the Odette and how to manage those patients and work with those patients. And so again, psychiatry in those more extreme situations is a point of, I think, referral. Now, social work, on the other hand, is, again, if these are very more pragmatic concerns like money and work-related issues, managing those daily activities at home, serving as a kind of a hub for who and to refer to within the PFS program, but also to community supports. So connecting our patients with community resources is also a fundamental role of social work, and palliative care and end stage and end of life planning, of course, as well. And our social work colleagues can certainly speak to additional more specific roles they play with our patients. But I'm sort of presenting here those things that each of us in our respective disciplines don't do so much of or at all. And with psychology, again, we're very much, we have protected time to provide psychotherapy and counseling services. And so that really is the bread and butter of what we do at the Odette. But I will be speaking more specifically to the types of treatment and care that we provide. But certainly in general, if you have a patient who's having difficulty adjusting to their illness and various aspects of it, the impacts it's had on their identity and their role in relationship to their family members and caregivers, certainly coping skills is a primary aspect of what we do in helping our patients develop those coping skills or apply the coping skills, drawing on the strengths they already have, but sometimes learning new ways of addressing the issues they're facing while they're a cancer patient at our hospital. And also lifestyle modification is another aspect, I think, that we basically the health behavior change, supporting those kinds of changes. We've trained very well in principles of motivation and resistance and things like that. And so how to work constructively with patients who are trying to modify their diets, for example, or adopt healthier exercise habits or habits in general, or if they're trying to modify their sleep patterns, or also smoking cessation is another role, but again, working in tandem with psychiatry there. So I think that pretty much covers how I was wanting to make sure we sort of distinguish our disciplines. And I think at this juncture, I can turn it over to you, Elie, who will be talking about the interplay between the medical and psychiatric factors.
All right, thanks, Karen. Can everybody hear me okay?
Yeah.
Karen, yeah, okay, great. So interplay between medical and psychiatric factors. This is basically, a bit of a framework that that I use essentially anytime I'm encountering any patient or any sort of diagnostic question. I think, ultimately, I love puzzles. And I think any patient that sort of presents in front of us, at least for diagnostic clarification, there's a sense that, there's a puzzle that has to be put together and figured out. And there's actually a finite number of different sort of interactions at play between the medical and the psychiatric piece. Either when somebody presents, one example is that, or one option is that the medical piece is actually impacting the psychiatric, that what we're seeing on the surface is sort of medical leading to a psychiatric symptom. There's the next possibilities that there's a psychiatric issue leading to a medical issue. A third option is that there's an interplay, sort of double-sided arrow. And then the fourth option is that there are these two things happening in tandem that are just completely unrelated. And unless I'm missing something, there really aren't any other possibilities. These are the four, basic finite number of possibilities. And so we'll give some examples, but I don't know who is here today. I'm just sort of quickly scrolling at the list and trying to figure out people's disciplines. The only thing I like more than puzzles is actually doing puzzles with people. And so I wonder maybe if it's not too much of an imposition before I give the examples, I'm wondering if anybody can think of some examples and maybe if they want to unmute themselves or put in the chat box or raise a hand or anything. Does anybody have an example of, let's say, when a medical issue might be impacting or maybe mimicking a psychiatric condition? And I promise I won't wait more than about 5 to 10 minutes before giving the answer.
I'm just scrolling here to see Anne Carty, you're unmuted. Maybe, I'm not sure if you wanted to say, venture a guess. But otherwise, I'm not seeing any takers.
Right, and so the thing to remember is that these are all patients that we have all seen. If you work at the cancer center, and if you've ever had a patient who has come to see one of us, then they've fallen into one of these four categories. Is there anybody here who works in? Oh, okay. So Panina Greenspoon said brain tumor, hypoglycemia, hyponatremia. Yeah, Panina, are you able to elaborate just a little bit?
Maybe
Can cause confusion, personality changes. Yeah, exactly, right? So let's say somebody presents with confusion, personality changes, mood changes, really anything. Maybe they have major depressive disorder, it's possible, but maybe if they have a brain tumor and there's some, hormonal dysregulations that are causing biochemical imbalances, that perhaps it's those biochemical imbalances causing what we're seeing on the surface. So that's exactly correct. Karen, can you flip ahead one slide?
Sure.
So the example that we gave here is dexamethasone causing mania. So, certainly we now have two of probably many different examples out there that we've all seen, where an underlying medical issue is making somebody sort of appear psychiatric, so to speak. But in fact, where what we really want to do is we want to try to figure out or reverse or treat the underlying medical issue first and foremost. What about the second example here, where there's a psychiatric issue leading to or causing or looking like a medical issue? Does anybody have an example of that they've come across? Again, just to remind everybody, these are patients that you have all sent to come and see us, or anybody who works in patient family support. These are patients that we see. These are real life examples. Karen, if you flip ahead one slide, we'll see what I wrote down here. So let's say something like major depressive disorder causing low motivation or deconditioning. So this is the sort of patient where if any of you go to fill out an e-sheet, you're probably writing, patient is less motivated, or they don't seem to have as much energy. Do they need an antidepressant? If any of you work on C2, then this might be a patient where you might say to us, gee, they're not progressing the way they should. We were going to be sending them to rehab, and now we're not even sure if they're going to be a rehab candidate. Are they depressed? question mark. And then we come and see them and try to figure out is, do they have some sort of HPA axis abnormality? Are they in a sort of state of cortisol deficiency? Or might there be a major depressive disorder there that's causing them to be deconditioned? The third example, it's this bidirectional arrow. Karen, if you flip to the next slide, you'll see that the example we gave actually isn't in cancer. And when I was reviewing the slides this morning, I was sort of puzzled at why I did that. But this is, again, just one of many potential examples, somebody with shortness of breath who also has anxiety and COPD. So the question is, patient isn't able to wean off of oxygen as quickly as we would have thought. Is there an anxiety component? Or more under the umbrella of Odette, maybe this is a patient with lung cancer. Maybe this is a patient with radiation pneumonitis, or one of the, many different lung pathologies that might either mimic a psychiatric issue like anxiety, or might actually contribute to a psychiatric issue like anxiety. Anxiety, of course, can then also worsen underlying lung conditions, or at least the sort of phenotype of them. And so that's why there's this sort of bidirectional arrow. And then, of course, the last example is when these two things are happening in tandem, but they're actually unrelated. And so this might be somebody who has delusions or some other, psychotic symptom, who also happens to have schizophrenia and CNS disease. And then the question to us, of course, becomes, is this their schizophrenia acting up? Is this because of the brain tumor? Can you help us figure that out? And what we may end up discovering is that there are these two very real processes happening in tandem, but that are actually unrelated to each other. And so this is basically anytime I'm sort of approaching any patient, at least if we're being asked to think diagnostically, these are the four sort of categories or circumstances that we might encounter when we're when we're seeing a new patient.
It's kind of like which came first, or the chicken and the egg. If there's a question of which comes first, what's causing what, or what's exacerbating what. Andreia, do you have anything you wanted to mention or add at this stage? Okay. All this must sound very familiar to you as well. I have a question just on this schematization that you've presented here, Elie, and it just has to do with, so where would you put somebody who is claustrophobic, but also now has to go through radiation, or have to where they actually have to have their heads like held down for brain tumor radiation, for example? Where would that person, so they come in already having an anxiety disorder, and now they are going to have life-saving radiation treatment that's going to keep them or in any scan situation as well, same thing, but where do those folks fit into that framework?
So, so I guess the way I would think about that, if there isn't anything sort of weird and wacky going on, then essentially what we have is a patient with an anxiety disorder that is impacting their medical treatment, but where there may not be any underlying medical issue that's interplaying with the anxiety, just to sort of, to kind of, to really drive the point home. So if that same patient now needed steroids for whatever reason to treat whatever sort of inflammatory process or anything else, and the steroids then made their anxiety even worse, then we're looking at maybe scenario A or scenario C or something like that, which matters because we're then, ultimately the reason any of this stuff matters is in trying to figure out, well, what's the right treatment? And there's a difference between looking at example A, for example, dexamethasone causing mania, before we start somebody on lithium for new onset bipolar disorder, right? We want to make sure that there isn't, that we want to know what's actually causing the, the manic symptoms. So in the scenario that you that you asked about, Karen, what I would say is that if there isn't, if we've now decided that there isn't any other sort of medical psychiatric interplay going on, then really what we're seeing is somebody who's got the unfortunate circumstance of having a psychiatric burden that's going to impact their ability to seek medical treatment.
Right. Yep.
But that there isn't some other kind of like weird, wacky, interplay.
So that situation doesn't really fall into this framework so much. It's more if they have a like it's more where you're doing the differential between the medical.
Yeah, or if we really wanted to put it in, I'd probably put it in as scenario number 4.
Yeah.
That there's this psychiatric issue happening, that there's a medical issue happening. They're sort of unrelated. It's unfortunate that it's by virtue of the confines of the CT or MRI or whatever their worries are about the radiation table or anything else. It's by virtue of those, that literally that physical environment that their anxiety is getting triggered, but
right.
that these two things are happening in tandem.
But they're separate.
That there isn't sort of interplay.
Interaction.
Yeah.
Thank you. Okay, thank you very much. Okay. So moving along to basically, and this is one of the reasons, I think one of the main drivers for this was we really wanted to get across our scope of care and service at the present time, and basically what we do with whom and for how long. And just to go into greater detail about what we mean by psychology and psychiatry services, and I guess this is actually very much areas of overlap. We all are able to conduct psychodiagnostic assessments and diagnose with mental individuals who are suffering from mental disorders or adjustment disorders. We will, in that capacity, play a major role in liaising with insurers, for example, as well, when for long-term disability and whatnot. Then also we providing coping and adjustment counseling. So this again can be at every stage of the illness trajectory, at the stage of diagnosis, preparing for the treatments, coping with the treatment effects, and any kind of unexpected cancer-related events, or when those events are expected but they occur, they're always, I think, shocking, and people have to kind of scramble, and how do they adjust to those situations. Including also fear of recurrence. If there's going to be one issue that I think we all are managing to some level in our respective practices, it is this. It's sort of like the ghost in the room. If it's not being mentioned, it's there anyways, but it commonly is the presenting concern. I mentioned earlier health behavior change and supporting, as in this case, for example, smoking cessation, but even the example, Elie, you were kind of thinking about on your feet around a patient who it's not quite health behavior change, but it is very much a behavioral change. And I could see psychiatry and psychology working, implementing an exposure hierarchy, for example, to help that individual become less anxious about undergoing the scan they need or the treatment, the radiation bed, et cetera. And so again, adopting principles around anxiety management and exposure therapy, as well as health behavior change and motivational interviewing, motivational type of interventions is also, I think, an area of overlap. And of course, psychotherapy. I mean, this is a major life crisis, and folks are it's going to bring the best out of people, and also the most challenging aspects of our characters. And so if you're an anxious person, you'll become more anxious. You're prone to depression, potentially more depressed. I just see it as sometimes it's just like this exacerbating experience. And I think if you're prone to insomnia to begin with, it'll again heighten that. And then of course, there are the more understandable, even if you are very high functioning to begin with, the existential concerns, relationships become destabilized as a result of the whole cancer care trajectory and dealing with the diagnosis and the life-threatening nature of the illness. Certainly our treatments affect our patient's sense of their sexual identity and their sexual function and their sexual health. And of course that too whether or not there's a sexual piece, but self-esteem, it can interact with self-esteem and body image in a big way. Even, you know, reducing expectations around what one can accomplish. If you're prone to perfectionism, for example, or have very high standards for yourself and others, that's going to be another kind of potential focus of type of psychotherapy that we could provide during treatment or after. And of course, grief and loss counseling, not only in relation to bereavement, but also in relation to all the various types of loss that we all in this room, in this Zoom meeting, know too well are a function of being treated for cancer. I also just wanted to talk about what I think of as conjoint counseling. Right now, unfortunately, we're not in a position to be able to offer focused couples counseling in that the presenting issue is relational distress. In fact, but what we do offer is if we have a family member who either is a spouse or an adult child who is interested in being a part of those conversations, and we can help improve their capacity to support their partner, but the focus being very much cancer, then of course we welcome caregivers to join these sessions that we offer. And when we think about the different kinds of modalities, I think again between Elie and Andreia and myself and all the psychologists and psychiatry practitioners we have working with patient and family support, we're all probably a little bit of an admixture of some of these. We all have many different types of training and skill. This might sound, some of you, I mean, most people know about cognitive behavior therapy. It's almost part of our common parlance, but it's actually not the only type of therapy that we do. And it's not always indicated. I often, frankly, adopt a lot of strategies that I borrow on cognitive behavioral strategies and mindfulness, for example, but that my own orientation is more humanistic, experiential. I know that Elie as well and Andreia will be looking at these different types of approaches, but again, drawing on, it's like our toolkit, right? We draw on what makes sense given the individual's personality structure, their presenting concerns, whether or not they have a history with some of these issues. And so we're really kind of trying to develop our own, I guess, therapeutic cocktail of what we think would be advisable with the individuals that we're seeing. And in terms of psychopharmacology, Elie has some words to say about that.
Yeah, so just as we were putting together these slides, we thought it might be helpful to talk just a little bit about sort of on behalf, I guess. So I'm now speaking sort of on behalf of the psychiatrists in our group. My hope is that what's on the slide won't be news to most of you, but we thought it'd be important just to kind of review nonetheless. I'm sure all of you know that we only take referrals from all of you, right? From the med-surg, rad-onc providers at Odette, from palliative care, any allied health who are in attendance today know that sometimes you'll sort of put in e-sheets on behalf of the physicians at Odette. But certainly we don't take referrals from family doctors, or at least not commonly. I'm sure we can all think of like an exception here or there. And also within psychiatry, we don't take self-referral either. As you know, OHIP billing requirements require us to have a referral from another physician. So that's just, kind of just trying to provide some sort of like pictorial representation of what I'm hoping you already know. Something that you may or may not know is that we tend to provide what we call an episode of care. And so unlike in F-Wing or unlike in other psychiatry departments where a patient might come in referred from a family doctor, psychiatrist will see them once for an assessment, and then they'll send a letter back to the family doctor. What we tend to do is provide more of an episode of care which basically means that we try to get people stabilized, to have maybe some sort of sense diagnostically or some sort of sense of a treatment plan, before, eventually either sending people on their way, whether that means asking them to see their family doctor to take over prescribing, or, seeing if they can try find a therapist in the community, or whatever that on their way might mean. I'm trying to really just kind of establish some sort of sense of stability, and some sort of foundation in terms of a treatment plan, before, kind of ending the work with them. So what does that actually mean? Is it 1 session or 5 sessions or 10 sessions, or, that sort of depends on the patient and the circumstances, but essentially the idea is really trying to get people somewhat stabilized. So I gave some examples here, of what that might mean. Maybe an oncologist sends a 49-year-old woman with breast cancer who's on tamoxifen, who also has hot flashes and depressed mood, no real past a psychiatric history, and they're wondering which medications they might want to start to try treat, let's say, the hot flashes and the depressed mood. Is this somebody that we need to follow forever and ever? Is this somebody that actually we need to see more than once? What does everybody think?
No to
Certainly
following
anybody,
forever.
no to following forever. Yeah, good, for sure, for sure. Is there anybody here today who actually works on M6? Like in the breast or sort of breast center affiliated? I'm running through the list and I see many names that I'm not familiar with. So unfortunately I can't call on people because I don't know, but in the spirit of honesty and transparency, if there's anybody here on M6, would you be okay unmuting for a sec? And oh, okay, so Yonina said, I do, but I'm only a research assistant. Only a research assistant. All right, fair enough. So I think that's Yonina's way of saying, don't pick on me. So I won't pick on you. But is there anybody else who works on M6 or who's ever come across any patient with breast cancer ever? And it's possible if not. What I would say is that this is a case that's pretty typical. And obviously we would do a full assessment to see if there is anything that we can file under kind of weird and wacky or major curveballs or red flags. But I think in the absence of those things, this could be something where we could actually see a patient once and leave some recommendations for the oncologist. I have a feeling actually the oncologists probably end up prescribing a lot of these same medicines even without referring patients to us. In fact, just by sheer volume, they probably do this much more frequently than we do. But certainly if they were having trouble or had any big question marks, they could send somebody and we might see them once, or we might, this is maybe somebody that I'd see like a couple times just to make sure that they're tolerating the medication and that there isn't, again, any sort of curveballs. And then we'd probably just, send them on their way. Another example is, let's say, a 63-year-old with GBM who's on temozolomide, who's getting olanzapine for nausea, and who has hallucinations and some sort of persistent hallucinations, I guess. Any thoughts on if this is somebody where we might just kind of make a recommendation once, or might see somebody a few times, or might see them, lifelong? To know the answer, you'd have to either be able to read my thoughts, which I'm hoping nobody can do, or you might actually have to work in the CNS disease site. You'd have to have some understanding that GBM sometimes has a very guarded prognosis, although not always. And that it's actually not inconceivable that somebody might benefit from our help on an ongoing basis, sometimes even through towards end of life. And that the reality is that doesn't always mean that we're signing on for a many decades long relationship with somebody. This, I'm obviously speaking in like incredibly broad strokes here, but this, I see many folks with GBM, many of whom I continue to see on an ongoing basis, not every week, certainly, but who over the course of, some number of months to a few years might really benefit from having a closer set of eyes and ears on them. The whole nature of GBM, really any sort of brain tumor, whether primary or secondary, means that all bets are off in terms of what somebody might be presenting with and how they respond to medications. And so it's often not so easy to just say, well, try this, and get back to me if it's not working. We really have to be able to see the patient and kind of follow them over time. The next major bullet point, the collaborative care with psychologists or social workers, this is in some ways it's self-evident, right? We all work, if anybody's ever been to patient family support, there's that hallway that we all share where at least pre-COVID, there was often a lot of physical interacting with our colleagues. And so, it's not that uncommon that that we'd be able to talk about cases, and if ever there were issues that a psychologist or social worker were having with a case, I'm wondering if maybe medications might be of help. Certainly, we would be able to easily collaborate with them. I just wrote down one example here: 72-year-old man referred to psychology now with worsening depressive symptoms. This is not a terribly uncommon scenario where a psychologist or social worker might reach out and say, I think they probably need medications. Can you do an assessment? We do the assessment. And at that point, I certainly wouldn't be taking over for more of the psychotherapeutic treatment that they're getting from the psychologist. I'd probably prescribe whatever needs to be prescribed and see them relatively infrequently, knowing that they're getting whatever other care they need from the psychologist or social worker that that sort of prompted the consult in the first place. And the last example I gave here is consultation to the oncologists or the teams. In CL psychiatry, there's often this question that we ask ourselves, like, who do we work for, right? Do we work for the patient? Do we work for the oncologist? Are we working for the cancer center? Do we work for CCO? There's really like who's the client? Who do we work for? Who do we answer to? And so one of the big domains of the work that we do is really that we work for the oncologists or for the teams, perhaps more broadly speaking. And part of that means, despite what the oncologists or the teams might wish sometimes, that we could sort of just take over a patient and kind of deal with all of their distress and just leave the rest for them to work with. Sometimes what it means actually is that we don't work with the patient directly. We work very indirectly, maybe through consultation with the oncologist or the team, either to help guide them or for it to be a bit of a venting session, because sometimes, let's face it, that's what we need. The example I gave here is a sort of prime example. 63-year-old female with personality disorder. She comes across as demanding and dismissive, somewhat entitled and narcissistic. The oncologist is prescribing Ativan because, of course, they pick up that there's obvious distress here. But Ativan isn't really going to help the same way that us seeing the patient directly isn't really going to help, right? We don't have a treatment for most, at least major personality disorders. So the treatment per se, if you want to think about it that way, is actually in helping the team make sense of the patient and understand the patient, understand ways that might facilitate tolerating the patient a little bit more easily, or some of the things
not personalizing necessarily. Yeah.
Not personalizing, exactly. And so this has happened as well, is that there are times that I might actually just meet with the team, with the oncologist or with the team as a whole, in talking through the case rather than seeing the patient themselves. Again, the wish obviously is if I could just see the patient and somehow make everybody's job easier, like obviously I would do that. But what we know about a lot of these patients or with these certain pathologies is that it doesn't actually help And so sometimes working with the team to help them understand this, to help them make sense of it. Karen, as you said, to not personalize it is really where it's at.
Thank you, Elie. Yeah, and just to say that sometimes, not to say that personality disorders are not treatable, but they are very long-term work that's required, and that's not the point of this in this context when you have an individual who's creating a lot of maybe difficult, strong feeling, and it's interfering with the delivery of the medical care, medical treatment. That's not the time to pursue a course of work on a personality disorder, even if the person is motivated to do that, which is a whole other kettle of fish. I just want to underscore that point that I think in those instances it makes sense to be more of a coach, and how to structure and how to, like you say, be more tolerant or understand by virtue of understanding what's maybe the hidden need or the kernel of truth underneath what they're saying, even though it's maybe offensive or difficult to engage them around. Okay. So moving along, thank you for that, Elie. And actually, before I do, Andreia, I'll just check in with you. Is there any other point you might want to raise or stress in relation to pharmacotherapy?
I don't think so. And we're going to talk a little bit more about that in my slides too.
Okay, great. Okay, good. So moving along to the principles of care. And of course, this is a balance. I should have had like a scale here, just as the icon to show really what we're trying to do is we've decided we want to reach the greatest number of patients who could benefit from our services. And so it's a balance between serving fewer patients for longer versus more patients for a shorter duration. And ultimately, it's the latter point at which we've kind of coalesced around. We think that that's the most fair and equitable approach to take in the face of having limited resources. And so one of the other things we've tried to do is be very much clear about that the issue that's coming to us is not due to some long-standing unrelated issue or concern. And now is their opportunity to finally see a psychologist or psychiatrist. I know that both Elie and Andreia have strong feelings about that, and we'll speak to that momentarily. But just to say that really we are looking for that the issues that they're struggling with are specific to their cancer diagnosis, treatment, and the fallout of treatment or side effects of treatment. And that doesn't have to be rigid. I mean, of course, even if it's impacting a relationship, yes, the relationship might have had issues to begin with. This has made things even worse. That would still be in the realm of what we feel we are treating. And that cancer has led to exacerbation of distress in other areas. And so again, just we have an eye towards making sure that that's the presenting issue, or we can at least justify utilizing our service for this particular individual because there's a cancer element to it. Let's put it that way, a clear cancer related element to it. And also, we are also wanting to recognize and refer to appropriate treatment programs where possible and appropriate. And just a couple of quick examples I have from my own practice over the years. I was working with an 18-year-old daughter of a patient. So she herself was not being treated for cancer with us, and it was more supportive psychotherapy and, I guess working around issues that were appropriate to her life stage. And at some point I got a phone call from her mother that her daughter was seen or known to have binged and purged. And suddenly I was now in a whole other area, a whole other territory, and I don't treat eating disorders. It's not one of my areas. It's not my scope of practice. And so part of the work then became quite quickly, being upfront about that with her and retaining the alliance, but also easing her in the direction of getting proper support and treatment for what was really early stages, I would say, of a potential full-blown eating disorder. So in many ways, it was actually good that I was seeing her for cancer-related concerns when this came up, but still. Another is of a patient who is being monitored for high-risk breast cancer. And in fact, I think this was something that her family doctor had initiated because she was so anxious about possibly having a cancer that she herself, and I'm not sure if this was, she somehow slipped in to being seen by our high-risk clinic. But in fact, what she was benefiting from was having more regular physical breast examinations. And over time, it became clear to me that she was likely struggling with a more of a health compulsive behavior in relation to her breast checking. And no matter how much she was reassured, even, you know, and it was always like those windows after her most recent physical exam and I guess the scans, that she would maybe have a little bit of a dip in her anxiety, but ultimately she would spring into action. And it was very clear that she needed to be treated again. We referred to the appropriate clinics to treat her obsessive compulsive disorder, which happened to focus on her potentially having a breast symptom for breast cancer. Similarly with borderline personality disorder and substance dependence, or if you have a history of trauma, oftentimes our treatments are echoing or re-traumatizing, not because they're in and of themselves are traumatizing, they can be, but more because it's that overlay on a pre-existing trauma. Or also common is when patients have a history of complex trauma, let's say, and or abuse, and they've now completed their treatment, and they've maybe even completed their course of therapy with one of us, but realize that this is something they really do need to kind of delve into more deeply and address, and it's never been really adequately addressed. And so that may be an example of a referral to our colleagues at Women's College Hospital and their Women Recovering from Abuse or RAP program, et cetera. So we know when to refer, and we are connected to help orient or connect our patients with the treatment they need, and also to provide as comprehensive a care as possible. So again, of course, as Elie was sort of describing, that working, actually physically in the same space when we can, but very actively working and collaborating with our PFS colleagues, and of course, referring to community resources as well. That's sort of the main drivers. And we want to reach our patients as quickly as possible, which sort of circles back to the first point, which is the more patients we see for longer, the less quick we can see other patients. And our wait list is not short, even with these restrictions that Andreia is going to be speaking to right now.
Thank you. So this is like to summarize our treatment criteria. So basically, kind of patients that we tend to accept as referrals. So the general idea is what already being said. I mean, we try to help patients cope with mental health issues in the active, during diagnosis, either new cancer or primary cancer or recurrence, and the active first stages of treatment, and help patients from a mental health perspective navigate, tolerate, cope with those aspects, and also initial stages post-treatment, that reintegration into life post-cancer. That's the summary, the idea. I'll talk a little bit more about one of those aspects, but that's the summary of the idea. For patients with advanced disease, patients with metastatic cancer, this is ongoing, so that would be more of a long-term support that we provide. But for the other patients, we had to come up with some time criteria based on those principles. I mean, with the resources that we have, how can we serve our patients and our teams better? And we came up with that idea that we take referrals for patients who are up to 12 months after active. We mean, for example, chemotherapy, surgery, radiation, active treatment completion. So that would be different from patients who are on tamoxifen, for example, post early stages cancer, breast cancer, which those patients can be on tamoxifen for many years, 5 years or more. So it's up to 12 months from, as I said, chemo, radiation, surgery, those kinds of treatments. And also we help patients with our high risk clinics. But before we move to caregivers, I want to highlight one of the aspects. As we were talking about all the interactions and what do you do, and that's maybe you can go back to the previous slide, Karen.
Yes, sure.
Which
one is it, do you think?
The principles of care, yeah.
Okay, yeah.
Because we might receive a referral for a patient who just been diagnosed or in very early stages of treatment. But it's also important that we look into the aspect of cancer has led to exacerbation of distress. And I think in psychiatry, there are some examples. For example, let's say a patient who has schizophrenia and they have a psychiatrist, they are stable on their medications, or maybe they are not 100% stable on their medications, but they are working with their psychiatrist to get them stabilized. Ideally, that patient would follow up with their primary psychiatrist. It's a lot of changes already in the life of that patient to be starting with the new psychiatrist on the top of everything else that's happening. Like often it's a case-by-case basis, of course, and I understand with system issues and etc. and so forth. There are more detailed. There can be many more details to those sorts of situations. But generally speaking, we would be trying to help patients where there is that relationship with the cancer, causing the mental health distress, exacerbating, which is very common, it is most patients that we end up seeing. It's a very common clinical scenario. Someone has had depression for many years, someone has had anxiety for many years, or marital dysfunction for many years, and the cancer adds to that injury. And we will see those patients, of course. Yeah. And we also help caregivers in the context of being a caregiver, coping with the caregiving per se, the burden of the caregiving, grief and loss and bereavement as well. We probably would defer caregivers who come with other difficulties. For example, what Karen has just mentioned, someone who's coming with a history of eating disorders or bipolar affective disorder, even though they don't have perhaps yet referrals in the community, ideally those patients would be seeking referrals in the community instead of coming to us. And should we talk a little bit about details of referrals? I think Elie touched on e-sheets for psychiatry, and we need an MD referral. For psychology, can be self-referral or e-sheet as well. Yeah. Right?
Yeah. Just seeing where we put that actually. Oh yeah. So in terms of the referrals, patients can be, sorry, I'm a bit confused by the slide.
I think it's on the slide 16 is one of the notes, perhaps. I think it's when you're talking about that one, more like concrete criteria, I think.
Right, yeah. Well, maybe we should move along just in the interest of time, yeah.
And why don't you talk about the length of treatment for psychology?
Yeah. So again, this is just how that balance that we were trying to strike actualizes itself. So for primary diagnosis patients, psychologists will provide one intake session and then up to 6 sessions of counseling and or psychotherapy, and we'll space those sessions in consultation with the patient or the caregiver if the client is the caregiver based on their needs. But if it's an individual who's presenting with recurrent or metastatic cancer, it's the same thing, but then we anticipate ongoing provision of support. We try to limit it to 4 sessions per year thereafter, and there's no limit, of course, on end of life. And then here's with psychiatry, Andrea, you're saying.
Yeah, I think Elie touched on that already for the sake of time. We have no fixed limit in terms of number of sessions. It's a clinical-based decision making. Yeah.
Okay. And right now we're looking at about a 4 to 6 wait for initial consultation with psychiatry or psychology, but it's on occasion we will be able to get somebody in if it's really an urgent assessment, especially on a cancellation. So it's not impossible, but for the most part, we are trying to pace those new referrals so we can also manage new influx of patients with existing treatment needs of our existing patients. And if a patient is in acute distress, then it is often the case that our social work colleagues will have the initial conversation with those patients in clinic. And then again, yes, we mentioned here that psychiatry could see sooner if the oncologist reaches out directly. There are some gaps, of course, in what we can offer, and I've mentioned some of them. None of us, at least within psychology, are licensed to work with children or youth, for example. So 18 was my bottom cutoff personally, because I'm only licensed to work with adults. And we're at time. We're at 1 o'clock. I'm sorry that we didn't have as much time, but I'm happy to stay behind if anybody has any questions. If Elie and Andrea, you're okay to stay, or if you need to.
Yeah.
Perfect. So we'll reserve 5 more minutes for questions for those of you who have them, burning questions, or otherwise feel free to ever email any one of us, and we're happy to answer. But I'm just going to pause and try to gauge the room, look around here and see if there's any additional folks that have a burning